Microphone check, 1, 2, 3. Microphone check, 1, 2, 3.
The committee will come to order. Before we begin, I'd like to just take a point of personal privilege and acknowledge the ranking member, Mr. Lewis. You know, it's often said that people look at the United States Congress today and they can be pretty discouraged and pretty overwhelmed by what happens up here. And I began to reflect on that a little bit, and I have been, for the past several months, sitting next to a man who brings everything that's good about this process to the forefront. That is John Lewis. And when I took over the gavel of this subcommittee, I knew he was the ranking member, and I knew he had an autobiography, and I read it. And I was fascinated by it. And the part that fascinated me, oftentimes I put myself into the place of someone that I'm reading about in terms of time and place, and I began to think, and I read about what John Lewis did in the summer of 1961. That is, he took on an incredible physical and moral challenge to be one of the original freedom riders. That was to integrate the interstate bus system and all of those things around it. And I was thinking, well, what was I doing in the summer of 1961? Summer of 1961, I was comfortably in my mother's womb to be born later on in September of that year. And as I've thought about it, and I had planned to do this before the events of Charleston, and now the events of Charleston have come upon us. And as I've thought about it, I've thought, what a privilege to sit on a dais with somebody who worked so hard to improve the world for all of us. Because we are all better off, every one of us, regardless of our racial background, we are all better off today because of the work and the tenacity and the moral clarity and the courage in light of physical trauma that John Lewis, as a very young man, was willing to endure. And so I bought a copy, or we have a copy for every member, Walking with the Wind, a memoir of the movement by John Lewis. And I would even go so far as to say that I bet you if you give him eye contact and corner him, he'll even sign the book for you. And I really commend it to you because it's a work that is an inspiration. It's a work that I think can guide us all. And it's an invitation, basically, to come with a sense of clarity to say, look, we can take on these things. If John Lewis was able to be a part of taking on a very broken and dangerous system that was legal segregation in the United States and was able to persevere through that, then surely we can take on and deal with a number of the challenges that are here before us. And so I am so deeply appreciative of his leadership and his clarity, and I am very anxious for my colleagues to read this. Now, since you don't get a copy of your own book, I've got a gift for you, and that is this. My wife Elizabeth is an oil painter, and she has painted a series of paintings, and this has not yet been published or put out anywhere, but one of the paintings that she has done is called Dreams of Freedom. And Dreams of Freedom is a portrayal of Martin Luther King's speech in 1963, and I know Mr. Lewis was there. I know he was inextricably linked to that time that was so pivotal in our history, the March of '63. And so I present this print to you of Elizabeth Roscom's oil painting, Dreams of Freedom, for you, and I hope that you'll accept it with the spirit with which it's presented to you today, Mr. Lewis.
Mr. Chairman, thank you so much for those kind words. Thank you for making Walking with the Wind available to our colleagues. Thank you and your wife for this lovely, beautiful painting, Freedom, portraying Dr. Martin Luther King Jr. standing at the Lincoln Memorial, delivering that speech. I was there. I was 23 years old, had all of my hair and a few pounds lighter. I spoke number 6, and Dr. King spoke number 10. And out of the 10 people that spoke that day, I'm the only one still around. Thank you for your friendship. Thank you for being you. And I will cherish this. With debate, I have an executive session with myself, whether I put it in my office or take it to my house. And just thank you so much.
Thank you.
Thank you.
Thank you. Well, and I should show the audience the print. How's that? So,
It's beautiful.
there you go. Well, let's get down to business, shall we? Today's hearing, we're going to focus in on this discussion about big premium hikes that insurance companies are currently proposing for 2016 under the Affordable Care Act. For 5 years, the administration has insisted that the law would reduce health care costs. The president said that we can cut the average family's premium by $2,500 a year, and yet the nonpartisan fact checker PolitiFact called that a broken promise. President Obama pledged that insurance premiums would go down, and yet the Washington Post fact checker rated that as 3 Pinocchios. And in fact, we're 5 years in, the health insurance costs under Obamacare aren't going down, they're going up. Now, under the House rules, the subcommittee's job is to evaluate the application, execution, and effectiveness of federal laws, and today we're going to do that. Now, for the first time since the ACA became law, insurers are able to look at a full year's worth of data claims to calculate premium prices for the year ahead. That's an important distinction. So we've got real data to talk about. The proposed premium hikes tell us a lot about how much healthcare costs last year and what insurers calculate healthcare costs are going to be next year. And on June 1st, CMS made public proposed premium hikes of 10% or more for the 2016 plan year, and many of the proposed increases are eye-poppingly huge. In Maryland, Care First Blue Choice, which covers approximately 80% of the individual market, has asked for an average increase of nearly 30%. In Missouri, Coventry Health has requested an increase of over 22%. In North Carolina, Blue Cross Blue Shield has asked for an increase of over 25%. In Tennessee, Blue Cross Blue Shield has asked for over 36%. In South Dakota, one of the largest insurers, Wellmark, has asked for premium hikes between 24 and 51%. It's noteworthy that in many states, the largest insurers are also the ones proposing the biggest increases, which is especially troubling if you think about it, because they've got the most data and are likely the most accurate. We could go on, but there are a number of these prices have real consequences in the lives of real people. In other words, this isn't just about insurance commissioners and scholars. This is about what people are actually paying, and they're paying this in the context of a false narrative. And the false narrative, in my opinion, was this is going to be great, your costs are going to come down, and you're going to love it. So here's a question. How many of Representative Noem's constituents in South Dakota have gotten a 50% wage increase? I would venture very, very few in order to pay for those. Now, to be fair, these are just proposals. Nothing's been finalized yet. In 36 states, state insurance authorities must approve the increases, and often after negotiating with the insurers. But there's a reason that the insurers are asking for such big rate hikes. The Affordable Care Act isn't working to lower costs, it's actually driving them up in many circumstances. President Obama said that under the ACA, more people would have health insurance so that the cost of costly emergency care would diminish. But in order to keep costs down, these plans have relied on narrower provider networks, meaning fewer doctors and limited availability. And also, much of the new law's health insurance coverage came in the form of expanding Medicaid. Since many individuals can't get in to see their doctors and many doctors aren't taking Medicaid patients, the net result is that the ACA is ironically driving the number of emergency room visits up. Just the opposite of what the president said and hoped would be achieved. Are these effects of the ACA just growing pains? I don't think so. The law created a number of temporary programs to bail out billions in taxpayer funds during the first few years to lower the costs seen by individuals and to protect big insurance carriers against financial losses. But those programs are beginning to phase out. And as the government is slowly taking off the training wheels, the Affordable Care Act is looking pretty wobbly. Even with the billions and billions of taxpayer dollars spent to reduce the sticker price of insurance for individuals, to lower their out-of-pocket costs, to pump up big insurance companies, to establish and operate the insurance marketplaces and more, all hidden and shifted costs paid by the taxpayer. Even with all that, health care costs and health insurance premiums are still going up. On its website, the Department of Health and Human Services says this: a new wave of powerful evidence points in one clear conclusion. The Affordable Care Act is working to make health care more affordable, accessible, and of higher quality for families, seniors, businesses, and taxpayers alike. But look at the facts. Premiums are going up, emergency room use is rising, co-ops are failing, and there's certainly a new wave of evidence, I would argue, and that's one that's pointing in a different direction, and that is that the Affordable Care Act, or Obamacare, is not working as promised. We're going to have a robust discussion in a couple of minutes. We will introduce our witnesses, but now I'd like to recognize Mr. Lewis for his opening statement.
Good morning. Mr. Chairman, I want to thank you for holding today's hearing on the Affordable Care Act. I would also like to thank our witnesses for being here. We are always pleased to discuss our landmark health law. And I will begin by saying that I've said at countless other hearings, the law works. The ACA is the law of the land. It was the right thing to do, it was the just thing to do, and it was long overdue. I believe in my core that health care is a basic human right. It should not be reserved for a select few, for the rich, or for the wealthy. Each and every one of us must do all we can to make this country better for the least among us and for generations yet unborn. We have a duty to speak up and speak out on behalf of people who have no one to stand up for them. The Affordable Care Act responded to the desperation of countless Americans who had a need, a right to health care. The law provides real benefits to American families. Today, over 16 million people who did not have coverage now do. More than 100 million people with existing health conditions can no longer be denied coverage. Millions of young people can now stay on their parents' insurance plan until age 26. And over 9 million hard-working Americans have received tax credits to make health insurance affordable, just as Congress intended. During today's hearing, I would like to learn more about how premiums are being set for next year. Many have heard or read stories in the press. But these stories may overlook future rate cuts and instead focus on proposals that still must be reviewed under the law. Although these rates are not yet final, I look forward to hearing more from our witnesses about what they think the final rates will be. Again, Mr. Chairman, I would like to thank you for holding today's hearing. Thank you very much. And I yield back.
Thank you, Mr. Lewis. We'll hear from our 4 witnesses, 2 of whom I'll introduce and 2 of whom will be introduced by members of the panel. Our first witness is Al Redmer, Jr., who is the Commissioner of Maryland's Insurance Administration. He'll testify about the costs of health plans within the state of Maryland and the experiences with Maryland's state-based exchange. Then we also have Seth Chandler, an insurance professor at the University of Houston, who will testify about contributing factors regarding the premium spike. And I'd like to recognize Mrs. Black to make an introduction.
Thank you, Mr. Chairman. I want to thank you for allowing me to be here with you on committee as a non-committee member. And I'm very proud today to introduce the commissioner of my state, Julie McPeak, and she is the Tennessee's Department Commissioner of Commerce and Insurance. She serves in this role under Governor Haslam, our current governor, and she's been doing so since 2011. And she brings 15 years of experience with her in the legal and administrative experience in state government. I'm also proud, extremely proud to tell you that she has been a commissioner of commerce and insurance in 2 different states before coming to the state of Tennessee. She was the commissioner there in Kentucky, and she is the first woman in the country who has had this title of being able to serve in 2 different states in this position. I really appreciate her dedication to our state. She's done a great job. She's committed to the state, and we have the most robust competitive insurance market possible hearing under the current law. And I look forward to having her testimony today as she talks about the impact of the ACA, in particular on my state's insurance marketplace, specifically on the premiums and also the laws that impact our enrollees. So it's my pleasure to have her here with us today.
Thank you. And Dr. McDermott?
Thank you, Mr. Chairman. It's my pleasure to introduce my colleague, Mike Kreidler. Mike, before he got involved in politics, was an optometrist. He could see clearly. He worked for 20 years for a group health cooperative in Washington State, so he understands managed care and has been very deeply involved in that on a personal, professional level. I got to know Mike when I was in the state legislature. He was there for in the 70s onward, and then came for a very short stay in the United States Congress. He was here 2 years, and fate and the tides of war took him home again. But he kept up his public service by becoming the insurance commissioner in the state of Washington. It has been such, I've forgotten how many years it is, but it's got to be 15 by now, isn't it? And he's a very knowledgeable man, and I commend him to the committee. He knows about both on the doing side as well as the public policy side.
Thank you. For our witnesses, your written statements are part of the record, and you've got 5 minutes. So, Mr. Chandler, we would welcome the opportunity to hear from you. Put the mic on, and then you get the joke on this. Green, yellow, red, there's a light that'll be fairly intuitive. And if I have to explain that to you, it's hopeless. Okay.
Thank you very much. My name's Seth Chandler. I'm a law professor at the University of Houston with specialization in insurance law and healthcare law. I do a lot of work using mathematics to enhance legal analysis, and I'm here today to testify on some of the anticipated premium increases and their sources on the exchanges for 2016, with an emphasis on 2 of the famous 3 R's. Point 1, we need to be careful in looking at premium increases. There are many occasions on which the net premium increase actually seen by an insured, which I think is the most important thing, will be considerably higher than the gross premium increase, a fact likely to diminish individual choice and induce policyholders to purchase lower-cost silver HMO policies. Second, the phase-out of transitional reinsurance and the Cromnibus alteration of risk corridors is unlikely in most cases to play a large role for any particularly large premium increases for 2016. Third, the major source of increases is likely to be higher than expected claims from insureds, particularly in the more generous platinum and gold and PPO plans. Now for some details. Net premiums, the amount paid after lawful subsidies are taken into account, not the published gross premiums, are what matters to most people. And as I show in my technical appendix, it is a matter of indisputable mathematics that net premium increases under the ACA are not the same as gross premium increases. This fact can convert a 10% gross premium increase into a 15% net premium increase. It can convert a 10% gross premium increase into a 12% net premium increase in a way that may impel the purchaser to experience a 50% increase in out-of-pocket costs. People on both sides of the aisle take note. The poor bear the brunt of this math. The more heavily subsidized you are, the higher the percentage price increase if you want continuity of insurers or continuity of care. Based on the actuarial value continuance tables created by CMS for its regulation of the Affordable Care Act, I have computed the reduction in net claims expenses created by the transitional reinsurance programs for 2014, 15, and 16. The TRP, as retroactively modified last week, reduced insurers' claims expenses by 14 to 16% in 2014, depending on the metal level. And by the way, prior to the change last week, the figures were 11 to 12%, meaning that insurers large and small just received a 3% cashback rebate from the federal government for 2014. For 2015, the TRP should reduce insurers' net claims expenses by 3 to 4%, and for 2016, the figures are almost the same. And since the value of the subsidies has not declined substantially between 2015 and 16, it is difficult to attribute a substantial part of the premium increases for 2016 to the phase-out. Now, another source of premium increases for 2016, sometimes mentioned, is the modification of the risk corridors program by the Cromnibus bill. I did some research, and it looks like that is unlikely again to be a source of a significant change in premiums. Yes, it is true that insurers may only receive 37% or so of what they had hoped to receive under Cromnibus, but many insurers hope that they will actually make a profit under the Affordable Care Act. And therefore, the big picture is it's unlikely that when we are looking at particularly large increases, the source of those increases is the phase-out of the transitional reinsurance program or the alteration of risk corridors. Instead, let's look at what's going on here. Standard & Poor's has suggested that most insurers lost money under the 2014, and so it's natural to see them requesting a rate increase. But don't trust the insurers. Look at the Obama administration's actuarial value calculator, which it is using to regulate insurers to determine if they're providing value. If you look at that, it shows that the gross claims of insurers is going to go up by 13 to 14% in 2016 relative to 2017. Let me just conclude by saying that the ACA focused mostly on insurance markets. And in the absence of better medical cost control, one should, everything else hold equal, expect the federal bills for subsidies to increase. Moreover, it's likely to cause an escalation of premiums, particularly for the more generous PPO plans and gold and platinum plans. And if so, we will see a diminishing choice of physicians, potentially less continuity of care, and increased cost sharing for many individuals. Obviously, I'm speaking here before King versus Burwell is decided. A decision adverse to the Obama administration would not change the concepts I'm laying out, but it would change the numbers. In fact, one of the most interesting things is to think about what happens to the transitional reinsurance program if we have gridlock both at the federal level and the states. But if King versus Burwell is decided adversely to the Obama administration, you folks have a lot more issues to discuss. Thank you very much.
Mr. Kreidler.
Thank you, Mr. Chair. Thank you, Mr. Chairman, for the privilege to be here. Ranking Member Lewis, members of the committee. My name is Mike Kreidler. I'm the Insurance Commissioner for the state of Washington, elected to that position. I'm the longest serving insurance commissioner in the country. And as Mr. McDermott pointed out, I'm also a former member of Congress, too. As a provider, as an elected policymaker, and also as a health administrator, I've enjoyed working on the issues around healthcare reform. And I could be no more closer to it than to be insurance commissioner at a time like this. As insurance commissioner for the last 14 years, I've heard many personal stories from individuals. One individual for the ACA, a woman from Kent, Washington, called my office to complain about a situation where she wanted to have a child, so she wanted to do the responsible thing. She got health insurance. Unfortunately, when she was expecting to deliver normally and is scheduled to at the end of July, had to have an emergency C-section. Because it was in the 9 months, this is pre-ACA, but within the 9 months, it was not covered. She complained to our office. We intervened with the health insurer, got some reduction in the bill that she had voluntarily by the health insurer, but she wound up with a very large medical bill, and that was through no fault of her own. What we saw before the ACA was that we had almost 1 million people in the state of Washington without health insurance. That was 14% of the state's population. We had 11 insurers in the market, which was better than most states and pretty good, but consumers still wanted more choices. We carefully reviewed the rates that came before us, but we still frequently looked at double-digit rate increases that we had to approve pre-ACA. Many of the health plans also did not cover maternity or prescription drugs. The system was not sustainable. The costs were continuing to rise precipitously, and we saw the uninsured rate continue to rise. Now let's fast forward to today. The healthcare reform is working in the state of Washington. We have an uninsured rate from coming down some 40%, down to 8.5% since the Affordable Care went into effect. And we looked at the numbers going back, and that's the lowest numbers that we can have. A tracking, it goes back to 1987 numbers that we're looking at, and it's the lowest we've seen. Premiums are not soaring, the lowest rate request we've seen in decades. In fact, if you look at the plans inside the exchange now, if you paid the full cost with no subsidy, the average rate is $384 a month. If you receive a subsidy, it's $174. This year, insurers are requesting 5.4%, and 3% of that is actually going to the exchange to fund the exchange, 3% of the 5.4. We had 11 insurers in the market. That's pretty good. We now have 17 insurers and 240 plans for 2016. Consumers have more choices. The market is thriving. There are several things that we wound up doing that I think made a big difference. The state of Washington expanded the Medicaid program. We have 530,000 people through Washington Apple Health, and the other big action that I took was that when the president offered to say you could keep your canceled policies, I said no. We need to keep the one pool, so you didn't wind up with a good pool and a bad pool when it came to risk. And as a result of that, it helped to stabilize the market. So we don't have the problems with legacy plans or grandfathered plans that many other states have. And second was to create standards for narrow networks. We have standards in the state of Washington with network adequacy standards that we put into effect for 2015. In fact, we were the only state that wound up doing that. It's a level playing field. Insurers know what to expect, and that's one reason why we're looking at a market where we've seen a significant increase in the number of insurers, going from 11 insurers to now 17. That's a 50% increase in the number of insurers after the Affordable Care Act. The increases are some of the lowest in memory. 50% or more of the insurers more insurers are in the market, and the uninsured numbers in the state of Washington continue to plummet. The Affordable Care Act in Washington is working. I believe it's working for the country too. Thank you, Mr. Chairman.
Thank you. Ms. McPeak?
Thank you. Good morning, Chairman Roscom, Ranking Member Lewis, and members of the subcommittee. Thank you for inviting me to testify before the subcommittee on the impact that the Affordable Care Act has had on health insurance premiums. And thank you particularly, Congressman Black, for your kind introduction. As mentioned, I'm Julie Mix McPeak, Commissioner of the Tennessee Department of Commerce and Insurance. I have spent most of my career in insurance regulation, and I have a strong affinity for the country's state-based system of insurance oversight. Tennessee has a federally facilitated marketplace, an FFM for brevity. The ACA legislation was intended to have significant impacts, and in that respect, it has definitely achieved its intent. The ACA introduced rating and underwriting requirements that fundamentally reshaped how health insurance is priced, purchased, and administered. These new requirements make a comparison of pre-ACA policies to ACA-compliant policies a significant challenge. ACA requirements that are cost drivers in terms of premium prices are well documented and include prohibitions on pre-existing condition exclusions, guaranteed availability and issue requirements, and new essential health benefit benchmark plans that create a floor for ACA-compliant plan benefits. The ACA significantly impacted an insurer's flexibility to design plans to meet consumer demand. In a post-ACA world, plans across carriers are much more similar than they are different, and carriers compete primarily on name recognition, physician networks, and premium price. The impact of the ACA on Tennessee's consumers, its marketplace, and rates has created significant challenges and uncertainty across the state's insurance landscape. Tennessee has been fortunate enough to experience consistency among the carriers offering policies to our residents. In the first year of the FFM, 2014, Tennessee had 4 carriers total writing policies, but only 1 offering policies in all 95 counties. We have received filings for 2016 that show 5 carriers writing policies, but still only 2 carriers offering policies statewide. Outside the FFM, the ACA and its implementing regulations have had the effect of segmenting Tennessee's marketplace. So-called grandfathered plans and the grandmothered plans, which we were known as transitional plans, remain a large block of business across our state. This segmentation often creates confusion for consumers who know they have a policy with a certain insurer, but do not understand the block of business that includes their policy. Tennessee had competitive marketplace before the ACA, and that marketplace remains competitive today. Market competition, in part, gave Tennessee some of the lowest priced FFM products in the country. In 2014 and 15, Tennessee plans have ranked in the top 5 least expensive plans when ranked based on the premium price of the second lowest cost silver plan on the FFM. Having a competitive market, however, does not isolate Tennesseans from seeing significant rate increases. Tennessee insurance carriers offering plans on the FFM requested rate increases for plan years 2015 and 16 ranging from 0.4% to 36%, with the carriers comprising over 80% of the market requesting increases of 32.6% and 36.3% respectively. TDCI is reviewing the proposed 2016 rate increases, and according to federal guidelines, will need to approve rates by the middle of August. These substantial rate increases can largely be attributed to medical trends and utilization. In fact, our largest FFM carrier reported for calendar year 2014 a medical loss ratio of well over 100%. To put that into perspective, for every $1 in premium received, a company paid out over $1 in claims, operating at a net loss, not including the administrative costs of the company. The ACA's strict underwriting and business requirements have left carriers with few options to maintain or reduce costs. One option that Tennessee has experienced is the use of limited provider networks. The ACA also established the Consumer-Operated and Oriented Plan, the co-op program, to help create new market competition. Tennessee is one of 26 states to have an operating co-op. Community Health Alliance Mutual Insurance Company was awarded over $73 million in low-interest loans to establish itself in Tennessee. These first 2 years of operation have been challenging for CHA as the company tried to assert itself in the marketplace while also maintaining financial capacity. In 2014, CHA had rates that were on the high side of the market, and as a result, the company failed to achieve a significant amount of volume. CHA revised rates for 2015 and was very competitive with the market. In fact, CHA grew too big too quickly and approached the department with a proposal to freeze enrollment under U.S. Department of Health and Human Services guidelines. We agreed to the proposed freeze and worked with HHS to cease enrollment, thereby effectively taking CHA off the marketplace. The decision to freeze enrollment remains the right decision for the company and most importantly for Tennessee insurance consumers, but the process has not been as efficient as we had hoped. For 2016, CHA has requested an average rate increase of over 32%. We continue to review the rate request as well as the company's frozen status for marketplace purposes. The ACA and its implementation by HHS has challenged state regulators and carriers by creating and continuing consistent uncertainty. Uncertainty in the business of risk nearly always drives up costs or lessens competition. In the case of the ACA, I think it has done both. From the early days of the ACA until exchanges were rolled out in 2014, governors, insurance regulators, and carriers looked for guidance from the federal government on exchange structures and rules. Delayed or unclear guidance led certain carriers to sit out of certain marketplaces in these first few years to better understand the new market. I personally was told by 2 national carriers that this uncertainty contributed to their decision-making processes for the FFM and their decisions not to participate. My written testimony provides a more recent example of HHS guidance introducing uncertainty into the market, released after the carriers had submitted their rating proposals for 2016. Implementation of the ACA has been a challenge. We continue to review policy forms and rates for next year, but anticipate that Tennessee consumers will again see increased insurance costs in 2016. Again, thank you for the opportunity to be here, and I look forward to answering your questions.
Thank you. Mr. Redmer.
Thank you, Mr. Chairman, members of the committee. I appreciate the opportunity to testify on proposed individual and small group rate increases in Maryland, and I especially appreciate being here on the day that you chose to give tribute to Congressman Lewis. As some added perspective, I've been in the health insurance business my entire adult life, including time as a producer, time in the Maryland legislature, and time as a CEO of a regional health insurance carrier. Maryland carriers were required to provide their proposed rate increases on May 1st. We are currently going through our actuarial review of those proposed rate increases, and we'll make a final determination by the end of July. Maryland does have a state-based exchange. In the individual marketplace, we are seeing a low where we see a reduction of 0.3% by one carrier. We see an increase on the high side of a little over 30% by Care First, which is our Blue Cross and Blue Shield carrier, which has a significant majority of the market share. It's in part because they lost significant money last year, in part, I believe, due to the adverse selection of small employers disbanding their small group plans and those employees migrating into the individual marketplace. As a reference point, Evergreen, which is our co-op, they are seeking a price increase of just under 10%. In the small group market, we see a low of, again, Care First, our Blues plan, asking for a reduction of a little over 16%. Evergreen, the co-op plan, is asking for an increase of a little, almost 15%, which is on the high side in the small group marketplace. For the proposed increases, what we're seeing as the cost drivers is an increase in the average morbidity as high as 15%. Increased medical trend, we're seeing a low of 3.5. The highest projection is 7, with projected profit margins in the 1 to 2% space. In 2016, we will see another year of uncertainty in the marketplace. One of the unforeseen factors, we just don't know what the answer is going to be the effect of the small group market from 50 to 100. As a matter of fact, Maryland increased the minimum allowable threshold for a stop loss. Minimum attachment point went from 10 to 22.5 in an effort to minimize adverse selection by going into self-funded plans. In the individual market, the uncertainty in part is going to be the increase in the penalty, whether that's going to drive any of these younger folks into the insured marketplace, or if it's just going to be the folks that have been sick in the last year or two migrating to the guaranteed issue marketplace. Also, I want to bring to your attention one of the unintended consequences of the Affordable Care Act. We have no regulatory control over it, but if you go back to January of 2014, we had thousands and thousands of small groups that wanted to delay the effects of the Affordable Care Act, so they chose to early renew. Instead of renewing in January, February, or March of 2014, they got in under the wire and they renewed in November or December of 2013. The effect of that, at least in Maryland, is we have a disproportionate amount of the marketplace, both small group plans and the individual marketplace, renewing at the same time, and it is an operational nightmare for both the carriers and the producers to handle that amount of work at the same time. Also, finally, Maryland's a little unique. There hasn't been an access issue in over 20 years. Everybody in Maryland, before the Affordable Care Act, had access, whether it was Medicaid for the poor or Medicare for the seniors. We had underwritten individual plans. We had guaranteed issue, guaranteed renewability with no pre-ex in the small group market. For those that couldn't get an individual underwritten plan, we had a state subsidized individual high-risk pool. So access was not an issue before the ACA. And with that, I'll be happy to answer any questions.
Thank you all. We'll start our inquiry. Mr. Kelly of Pennsylvania.
Thank you, Chairman. And I think all of you are here today. I really appreciate you being here, and I want to make sure that we get off on the right foot. This has nothing to do with us not having a heart and not wanting to help people who need health insurance. I want to make sure we understand that. And one of the things I think that is really critical, and Professor, I really appreciate your input. Mr. Redmer, thank you for what you're talking about. I'm an automobile dealer. We just went through the new package for our people. It's up over 30%. And the way we were able to keep it at that little bit over 30% was by working with the deductible a little bit. I got to tell you, back home where I'm from, if sustainable means capable of being sustained, here's what I looked it up because I want to make sure we understand. Sustainable is a method of harvesting or using a resource so that that resource is not depleted or permanently damaged. And so when we talk about these programs, and as a private business person, your model has to be sustainable or you're on a fool's errand. You won't be able to stay in business. And so as I listen to your testimony, I'm really interested. I got to tell you a little bit of what happened to me back home. I go to this little restaurant, Natilli's in Butler. Been there for a long time. Cindy is the girl that always waits on me. A year ago, she says, is there something you can do about health insurance? I said, well, what's the problem? And she goes, well, my husband's firm used to include me. Now they're not. I'm shopping right now. My monthly cost is going to be $700 to $800, and my deductible is $10,000. So I can get insurance, but for all intents and purposes, I'm not insured. So having an insurance policy and actually being insured against out-of-pocket, or what it's actually going to defray for you, there's two different worlds out there. And that's why I appreciate you all being here for, because I hear that in some cases it's down. In Pennsylvania, it is not down. It is going up. But rather than talk in terms, government terms, that are too lofty and often leave people confused and scratching their head and say, you know what, I don't get it, I'll just walk away, because I know the government will, at some point, they'll take care of it all. Professor Chandler, the model that we're on right now is not sustainable, is it? From a business standpoint, the model that we're on right now in the Affordable Care Act, first of all, it's not affordable in a lot of ways. I'm talking about people who actually have to buy it and pay for it. And then there's others that have to help invest in subsidies in order to make it more affordable for other people. So somebody has an out-of-pocket cost, and nothing is for nothing. Your testimony, I thought, was fascinating because I think you talked in real-world terms about what this means to people. Ms. McPeak, you're the same way. Mr. Redmer, the same way. We're talking about everyday guys and gals that get up in the morning, throw their feet out over the bed, go to work, put a roof over the head of their kids, put food on the table, clothes on their back, prepare for the future, and try to make sure that they're healthy. Every one of you talked in your testimony about a trajectory that is unsustainable. Am I missing something there or not?
In my opinion, Representative, it is very unrealistic to think that this country can afford a situation in which 17% of our GDP goes to health care, and that starts to keep going up and keep going up. It's estimated to go to 23%. Okay? Think about, yes, healthcare is important, but we can't run businesses, we can't run a society well in which that large a proportion of our GDP is being diverted into healthcare.
Yeah. See, our state's getting killed with this. Ms. McPeak, Mr. Redmer, if you could.
Thank you for your question. It's an interesting concept of sustainability. You know, certainly what concerns me are the large cost increases for premiums that have been requested in Tennessee. And I will tell you, we as regulators test every one of the assumptions that is included in that rate request. And in fact, the loss experience is there. So when you're considering a rate increase in the 30% range, and you know that that's going to affect people in your state, you really want to see if there's any margin to assess whether or not there's anything you can do to make that less uncomfortable for the residents of our state. The problem is, under our state authority, we have to look at the rates, whether they're unfair, discriminatory, or actually insufficient. And in some instances, with the experience that we have seen that have been filed in with the rate request, even the 30% increases may still be deemed insufficient, and we may need to order increases above those rates in order to protect the financial stability of the company. And in that regard, I don't think those rate increases are sustainable, because those insurers need to stay in business to make good on their promises that they've sold to every resident of our state.
Okay, well, I think you're all here for the same reason. I think we all have the same purpose. The worst thing in your life is to make a promise that you can't keep. And I think that somehow we went so far down the road on this and being affordable and accessible that we really missed the part about it being accessible and truly being affordable. And my worry is the unsustainability of the model that we have out there right now. It just doesn't work. The president's right. Do the arithmetic, and you're going to find out it doesn't bode well in the future. So thank you for being here. Appreciate your testimony.
Mr. Lewis.
Well, thank you very much, Mr. Chairman. Again, let me thank each of the witnesses for being here today. You're a good-looking group, beautiful, handsome. Mr. Commissioner, Commissioner Crowder, welcome back, my dear friend and colleague. Again, thank you for being here. I want to learn more about how people gaining Medicaid coverage help state insurance market.
Say that again.
I want to learn more about how people gaining Medicaid coverage help state insurance markets.
Thank you, Mr. Lewis, and the complimentary words that were directed to you were totally insufficient to recognize your broad achievements. So it's a pleasure to be here, to have an opportunity to take this question. The failure to expand the Medicaid program, in my opinion, has had very negative impacts on those states that did not, from the standpoint of their exchange market, and most of those are going to be federally facilitated exchanges. By virtue of not expanding, you wound up with people who would have been eligible for Medicaid either because of family members or others. They get them into the insured market, into the exchange, and as a result, you see much higher claims experience, morbidity numbers from the standpoint of the exchange. It is very positive to have done a Medicaid expansion from the standpoint of helping to hold down the rate increases. You artificially push up the rates inside the exchange by virtue of not also moving to do the Medicaid expansion simultaneously.
Do you think that this process could help states that have not expanded Medicaid, like my home state of Georgia?
Mr. Lewis, I would say that one of the things that I've seen as a very positive indication is that we see a number of states now moving to governors moving to try to address the issue of Medicaid expansion. And I think there's going to be a growing recognition. When Medicaid was first adopted back in 1965, we wound up with at least one state, Arizona, as I recall, held out for a number of years, but finally wound up joining. We have many more states that have not made the Medicaid expansion here now, but I think as they look at it and start to see the effects, one, on the rates inside the exchange, but also the effects on their citizens who would be eligible for Medicaid who are effectively locked out right now, we need to do something about it.
I know that that Washington has a state exchange, but if the Supreme Court were to decide against the government, would you please describe the possible impact on those people living in states with a federal exchange?
We actually had some experience with that, and Mr. McDermott will remember this. He was in Congress then, so he was away from it, but in the late 1990s, we actually had health care reform that had passed in 1993. It was repealed in 1995, but it left in place that you could get health insurance after a 3-month pre-existing waiting period. What the net result was, we effectively had what would be left with the Affordable Care Act is you could have guaranteed issue, and you would wind up with the healthy people dropping out as rates started to rise, the sick people staying, and you couldn't stick with it. In the state of Washington, where we had a comparable situation in the 1990s, the market actually collapsed. We lost our individual market. It took legislative action to see it restored just as I came into office in 2001. We would see in those 34 states that are in a position right now to have federally facilitated, they in fact could be in a position to see exactly what happened in the state of Washington, which is a collapse. This based, of course, on the failure of Congress to come together with a satisfactory resolution, and I trust that would be the case.
Again, Mr. Commissioner, thank you for being here. Good to see you. Thank you for your leadership.
My pleasure,
You're
Mr.
back,
Chairman.
Mr. Chairman.
Mr. Meehan of Pennsylvania.
Thank you, Mr. Chairman. Thank the panelists for being here. Mr. Redmer, your testimony, you made a statement that you've seen costs generated because there's been a 15% increase in morbidity. What is that?
That's basically I'll describe it as the health status of the pool is getting sicker. So they're going to be utilizing more services.
Okay, all right, I understand. That's one of the cost drivers. Mr. Kreidler, we are sitting here hearing testimony from two different places. We've got 30% increases on average in Tennessee. Mr. Chandler's talked about extensive increases in Texas. I'm seeing them in Pennsylvania, and yet you're saying that you have a 0.5% increase. What's going on?
Thank you for the question. Clearly, there are some stark differences among the states. I think part of what I tried to point out was that I think we were fortunate that we had a very competitive market in the state of Washington before the ACA came in, and it's become significantly more competitive. We have 50% more carriers in the market. Not all states have had the benefit of that. The second is making...
So your starting point, I mean, the beginning line is at a different place in other states.
Exactly, and it's had an impact then as we went through the process of implementing the Affordable Care Act. Where you started made a difference. We also had a strong history of doing rate review, and by virtue of having a competitive market, we saw better rates in the state of Washington than you saw in many other because of a competitive marketplace.
Well, so that is a point, though, and that is, I think, what's lost because we don't talk about it. It was never sold as, well, if you are in this state, it was a generalization that all Americans will either benefit or the costs will go down, and that doesn't seem to be occurring. As I said, what's the experience you're having with your co-pays and your deductibles?
Co-pays and deductibles are, I'll be frank with you, are a bit of a challenge because while you've been successful in limiting the total out-of-pocket expense for individuals, co-pays and deductibles have gone up.
Because that's capturing on the other end.
It winds up having that net effect for individuals, but if they get really sick, they really benefit. I mean, it puts a limit on their total out-of-pocket. So it's one of, do you want the insurance if you really, really absolutely need it, or are you willing to pay for some of the co-pays and deductibles before you reach the point where you achieve that out-of-pocket expense limit?
Well, let me close my questioning with Mr. Chandler and Ms. McPeak, and Mr. Redmer, if you have insights on these two. I made the point, and this is just the very generalizations that were made, that if, the average American's going to save $2,500 under the plan, and if you like your doctor, you're going to keep your doctor. Now, we're seeing in Pennsylvania, as an example, the rate increases in western Pennsylvania, where my colleague Mr. Kelly's from, 30 as high as 40% on average. And networks are narrowing, not expanding. So can you explain to me what is happening in the marketplace in the aftermath of those promises? Are we seeing the $2,500 savings, and are people keeping their doctors, or are networks getting narrower, and are narrow networks a good thing? Mr. Chandler?
I think that assertion deserved every Pinocchio that it received. What you are seeing is an entirely predictable result. community-rated plans in most jurisdictions have been subject to severe adverse selection problems, and I believe we are beginning to see precisely that with the rate increases we are seeing here.
Ms. McPeak?
Well, I certainly don't hear from consumers that are saving any money on insurance premiums. I hear quite the opposite from consumers that are calling my office. What I would suggest about the transitional plans, if you can keep your policy, if you like your policy, you can keep it. In Tennessee, we allowed those transitional policies to continue, knowing that that was going to further segment the market because we wanted to have those choices available to our Tennessee consumers. The problem was that position was decided by President Obama 45 days before the plan year started. So the rates were already filed and approved in our office. The plans were already on the federally facilitated exchange ready to be purchased. So allowing those transitional plans to continue didn't have nearly the significant effect, and the insurers were already locked into rates that they had already seen. I think what you're seeing in the marketplace with the increased deductibles, copays, and the limited networks are insurers and consumers trying to moderate some of those claims-based rate increases that are justified and trying to moderate those 30% into lower amounts. So they're choosing policies that, again, have the payment on the back end, as you described, or have such limited networks that they don't have the provider choice as before the ACA.
Thank you. Mr. Redmer?
Yes, two things. Number one, the narrow provider markets. This gives the carrier the ability to demand and extract greater concessions from those providers that are left in that narrow market. And I would speculate that if the markets are made broader and they have more providers, that's going to result in even higher price increases than we're seeing now. And when you talk about the effects on the consumer, and I just want to throw this on your radar screen because I think it's a national issue, and that's the significant unbridled cost of air transportation, primarily helicopters, that is resulting in balanced billing to the consumers, thousands and thousands and thousands of dollars, and these are folks that are not in networks. It's a significant national issue.
What choice do you have if you're lying on a turnpike after an accident and they call in?
You don't. That's the problem. You don't. And oftentimes the patient who has no choice has no clue that they're going to get a $25,000 to $40,000 bill there's going to be a balance bill from a helicopter service.
Time's expired.
Thank you, Mr. Chairman.
Thank you.
I yield back.
Mr. Doggett.
Thank you, Mr. Chairman. Thanks to all of our witnesses. Mr. Chandler, I was pleased that you drew attention to the fact that 17% of our gross domestic product is focused on health care, and that could arise to almost a fourth of our total national economic output. That was certainly a consideration in our writing the Affordable Care Act, in noting that despite the fact that we devote so many resources to health care, that we don't get the best outcomes versus some of the countries that are devoting significantly less. Of course, one of the objectives, and there were modest improvements in the Affordable Care Act, was to address the whole problem of soaring costs. One of the major omissions of the Affordable Care Act has been the failure to address soaring pharmaceutical costs. Indeed, particularly in the last year, the cost of the soaring cost of cancer drugs has been almost inconceivable. To see those who are facing a diagnosis of death, facing not only that, but a diagnosis of personal bankruptcy on their copays for drugs that are costing tens of thousands of dollars, over $100,000 for some, not only having the impact of personal bankruptcy, but threatening insurers and Medicare, given our inability to negotiate from Medicare on drug prices. One of the very modest steps taken in the Affordable Care Act was to set up an independent panel, but given the inability of Congress to address soaring health care costs. And so the action that was taken is that yesterday we repealed that modest cost containment provision that won't take effect for another 9 years, and paid for the repeal by limiting the
prevention fund, taking money that was designed to encourage preventive steps such as treating diabetes, preventing diabetes instead of paying for amputations. All of this done without any alternatives being offered as to how rising healthcare costs would be addressed. Today, we're speculating on an incomplete set of proposed premium increases that will not be finalized for months, that some states have the ability to deny or limit in the rate review process, and many states do not. Against that speculation, we have a certainty, and that is that if tomorrow at 10 o'clock or one of the next few days, the United States Supreme Court provides an adverse decision in King against Burwell, provides the result that Chairman Roscom, Chairman Ryan, my two Texas senators have sought, that would deny tax credits from families who live in our states, that those folks will see an extraordinary increase in their out-of-pocket cost. About 6.4 million people living in states that have refused to set up private insurance marketplaces at the state level will lose their tax credits. That's a cumulative loss of about $1.7 billion every month. In Texas, that would mean an average 305% premium increase for 800,000 Texans, at least in terms of what their out-of-pocket premium costs are. I'm concerned about what's happening with rising premiums. Commissioner Kreidler, is the increase in health insurance premiums, did that start with the passage of the Affordable Care Act, or did we have some issues concerning rising health care premiums before that act ever became law?
Thank you, Mr. Duggett. The issue of rising premiums has been with us for a long time, and since I've been serving as insurance commissioner 14 plus years now, I can tell you it's been a real problem that is actually looking better right now with the Affordable Care Act than what we saw before, the routine nature. We were seeing people who were sicker buying health insurance. If you were healthier, you didn't buy it. You opt in if you're and try to buy it when you're sick. It has a very negative impact on the market. Now with a mandate to have it, it's had the effect of helping to hold down the rate increases. But we need to do more than that. And one of the issues that you mentioned, Mr. Doggett, was the issue of pharmaceuticals. We need, and we're seeing a major transition to generics. And I'm very supportive of the health insurers who want to make sure that they go generics first, but they need to be able to go to brand name at the appropriate time. They can't discriminate unfairly against consumers who have bought health insurance. And when it comes to the issue of the narrow networks, that is not new. That was there before health care reform went into effect. It was something that large employers were instituting, had instituted in the past, the self-insured plans, which we, as regulators, don't regulate. But if it came into the regulated market, particularly inside the exchange, starting in 2014. But if it's done right, and that's why I adopted rules on network adequacy, if it's done right, it can improve quality and outcome and lower the cost. But you need to make sure you're holding carriers accountable. Don't let them determine the rules for themselves.
Thank you very much.
Mr. Renacci.
Thank you, Mr. Chairman. I want to thank you for the book, Mr. Lewis. It's an honor to serve with you. I look forward to reading that book. And the witnesses, I appreciate you all being here. It's interesting. I was in business for 28 years before I came here. I was in the healthcare business. And yes, premiums did go up. But if I ever saw a premium go up more than 8 or 9%, it was a shock. Today, when I go through my district and I hear 62% increase, 48% increase, 39% increase, it shocks me when I hear premium costs are coming down, or we use statistics that say they're coming down, because that's not what the real world is telling me when I get back into my district and I go to these employers. And one thing, when I do go to the employers, I ask them if I can talk to the employees, and it's interesting because it's a requirement. I want to talk to your employees. And I ask every one of them that they're buying their own insurance, tell me if your health care costs are coming down. Put your hand up. Now, I realize people are always afraid of putting their hand up, but I've only had one person tell me that the Affordable Care Act has helped them. Now, maybe I'm going to the wrong businesses. I don't know. But I seem to be going to business after business and talking to employees. And I also had a similar situation
that Mr. Kelly had. I had an individual at a local restaurant in Wadsworth, Ohio, say to me, Congressman, I now am part of the Affordable Care Act, but can you help me because my husband and I work 40 hours a week and we can't afford this deductible. So we really don't have insurance. And it's shocking when you hear some of those stories as well. I do go around to the hospitals. You know, again, being in healthcare, I'm always trying to find out what the Affordable Care Act has done. And I ask the question, has the emergency room visits increased, increasing? At the same time, we're learning about these insurance premium increases. We have been hearing, and I've been hearing, the emergency room visits are increasing. And without objection, I'd like to enter this May 5th, 2015 Wall Street Journal article entitled, U.S. Emergency Room Visits Keep Climbing into the Record.
So ordered.
The article explains that even though people have insurance, they can't find providers or get appointments with the providers they can find, so they are still going to the emergency room. Now, for the panel, I think you would all agree with this, but doesn't greater emergency room use lead to higher costs or lower costs? Each one of the panel members, higher costs or lower costs if we're going to the emergency room?
Certainly, I think higher.
Commissioner McPeak.
I would also say definitely higher, but in the state of Washington, we've actually seen about a 10% reduction in emergency room visits. And frequently,
Washington must be the only state. Ohio's not doing that, but I appreciate you. Mrs. McPeak.
if you go into an emergency room, what they wind up telling you is, if it's not an emergency situation, go down to urgent care down the street. It's going to cost you a lot less, and that's had a dramatic impact.
Commissioner McPeak.
I cannot dispute, I would say higher.
Mr. Chandler.
The issue is that once you're in the emergency room, there are a wild number of tests that will be performed. Insurers aren't capable of exercising sensible utilization review, and as a result, the costs can often be higher.
It's amazing because I always thought the purpose of ACA was really to, especially with subsidized insurance, was intended to reduce emergency room visits. And again, that's what I'm seeing in Ohio. Commissioner McPeak, you mentioned that many insurers have made changes in their networks to limit the providers people can see. What has your state experience been?
We are just now beginning to see very limited networks attached to rates and plans for the 2016 plan year. And as I mentioned before, I do think that that is an attempt by the insurers to moderate the rate increases that have been requested and provide choice to consumers so that you could have a skinnier network and potentially reduce your own costs if you're willing to take the risk that you may not have full access to the wide provider network to which you're accustomed.
How is the president's promise that you can keep your doctor if you like your doctor worked out in Tennessee?
Well, that's about the same as the promise that you can keep your policy if you like it, in my opinion. That's not working out very well, and we are hearing from consumers who are having difficulty navigating the federally facilitated marketplace to see where the provider lists are maintained and whether their providers are included, and they might get into a product that, in fact, does not have the doctor which they like.
Yeah. It's the same thing I'm seeing in Ohio. I think this is an important point. Just having an insurance card doesn't really mean you have access to care. I think you all agree.
I would agree for economic reasons, access reasons, and utilization certainly.
Thank you, Mr. Chairman. I yield back.
Mr. Crowley of New York.
Thank you, Mr. Chairman. Thank you as well for the book. I appreciate your kindness in giving it to all of us, and we can never say enough about the honor it is to serve with Mr. John Lewis here in the House of Representatives, particularly in light of what took place last week in the South and all that he has lived for, has put his life on the line for. The horrific events of last week have left a scar upon our nation, and no one knows it more than John Lewis. So thank you, John. I love you. You're a great man. I am a little bit baffled, though, by what my colleagues think they're going to accomplish today by holding this hearing. Yes, opponents of the Affordable Care Act have tried numerous tactics to scare people away from the law. That's nothing new. They seem to think that if they keep on shouting premium increases, Obamacare, death panels, then people will avoid getting insurance to the law, which is somehow a victory for them. But that's no victory for anyone.
Commissioner Kreidler, you've mentioned that enrollment plays a big part in keeping premiums stable. That's part of the very concept of insurance, isn't it? A bigger, let me just finish, a bigger, healthier pool of enrollees spreads out costs so premiums can stay steady. Isn't that not the case?
Very definitely. It's the law of large numbers. If you don't get good risk and bad risk and have large numbers, a large pool, it's very hard to control rates.
So all of a sudden, the sudden outrage over premium increases is going to have the effect of scaring people away from the ACA's insurance markets, making it harder to prevent those very premium increases. But aside from that, I don't understand this nostalgia for the way things used to be before the Affordable Care Act was in place, when insurance companies could do whatever they wanted for however much they wanted to charge. It's as if there were never premium increases, never problems with health care in the past. But that's not what my constituents experienced back in New York. My constituents in Queens and in the Bronx are small business owners who saw their insurance bills go up every year with no explanation. They were families buying insurance on the individual market who maybe couldn't shop around after getting hit with a double-digit increase because they had an old injury that would get called a pre-existing condition, and they would be denied new coverage. I'm proud that those days are days of the past. Commissioner Kreidler, today, if an insurance company just feels like raising rates to pad their profits without spending more on patient care, can they do that?
Mr. Crowley, what we see now is the insurance companies have to play by a standard set of rules, so they can't game the system. The game before was try to avoid sick people, only insure healthy people, and if you were one of the sick people, you were obviously kind of left out. Now with standard rules, we're actually introducing real competition between insurance companies, and that's one reason I'm so proud that in the state of Washington we've had a 50% increase in the number of insurers. So they're competing with a standard set of rules. It isn't the gaming that was employed in the past.
Well, it's also because the Affordable Care Act requires that 80% of the premiums go directly to better care. If consumers do get a rate increase notice, they are left to just shrug their shoulders. That's just the way it is. That's not the case anymore, is it?
That's correct. You know, in the state of Washington, we were fortunate that because we had a very competitive market, we had none that had problems meeting the 80% rule. That wasn't true for many other states, and it's one that now, because of the federal law, they have to meet as the standard.
And what can regulators in states like my home state of New York or Washington do when they see exorbitantly high rates going into, or the request for that? What can they do now?
One is that they have an opportunity to shop. They can go, if they have a carrier before, if you had a pre-existing condition, you couldn't move to another insurer because they wouldn't want to insure you because of your pre-existing medical condition. Now you have guaranteed issue. You can make choices. You can make decisions as to which plan, how much out-of-pocket expense do you want to have, what kind of coverage do you want, and you also want to make sure that your doctor and hospital. Now, I will agree that this has been one of the challenges that we've had, is making it a lot more transparent so it's easier to identify the hospitals and doctors that are in a particular carrier's network when you make the decision. But you have those kind of choices and didn't before.
What I can tell you is that in New York State, we have consistently used the authority to encourage, that was encouraged by the ACA, to fight premium increases. The state has come to the rescue and to stop that. So, Mr. Chairman, I just want to say I would suggest that 3 out of the 4 panelists would be opposed to the ACA. I'm just taking a guess, and 1 would be in favor of it. With that, I'll yield back the balance of my time.
Well, in answer to your, it was a rhetorical question, but I'll answer it. What are we trying to accomplish? What we're trying to accomplish is the work of the subcommittee under the House rules, which is to evaluate federal programs. We haven't had a bigger federal program since the passage of the Affordable Care Act. There's nobody that's nostalgic about the past. The irony is, when President Obama won his election, an overwhelming majority of Americans agreed on 2 things. They agreed that health care costs were going up at a rate which was unsustainable, and they were basically scandalized by the idea of not being able to get access to an insurance pool based on a pre-existing condition. The loss and the regret is that we're focusing in today is to say we should have focused in on those things, concentrated there, but instead the administration, and it was their prerogative, went a different direction. The false claim and the false narrative was it's all going to be great. You get to keep your doctor, premiums are going down. So it's not as if we're scaring people away from the Affordable Care Act. The Affordable Care Act is scaring people away from the Affordable Care Act. And with that, recognize the gentleman from North Carolina, Mr. Holding.
Thank you, Mr. Chairman. It's somewhat striking to me that there are many insurers out there that appear to have paid out more in claims than they're collecting in premiums. For example, Blue Cross Blue Shield of Texas has reported that it collected $2.1 billion in 2014, but paid out $2.5 billion in claims. So does anyone on the panel think that it's sustainable for an insurer to pay out more in claims than it collects in premiums? Kind of a uniform.
No, it's not sustainable, and of an observation is our Blue Cross plan has lost money in the last couple of years, and we've seen a reduction in their reserves. One of the reasons that they're coming back with the large rate increase, obviously, is because they've lost money. The gentleman from New York mentioned that if carriers don't hit a certain loss ratio, they pay rebates back to the consumer. So we've got a phenomenon where if you lose money, it stays lost, but you can only make it up incrementally, because if you make too much, it goes back to the consumer.
Right.
So we could debate whether that's good or bad, but you can only incrementally make any losses back. You can't make it up in 1 or 2 years.
So if you're an insurer, losing money under this scenario, I mean, your options are you can either raise your rates, raise your premiums, that you can just pack up and leave and stop insuring people in this segment and leave the state. Now this year, obviously, we have a very complete set of numbers because we've already had a year, the program being in place, and so insurers have a good idea of what they're dealing with. So what impact is the data review for the upcoming year having on the rates? And Mr. Redmer, you want to talk about that a little bit?
Well, certainly, you can see on my testimony, we've had one carrier that actually came in and is asking for a small reduction in the individual rates, and Care First, our Blues plan, is asking for a 30% rate increase, and it's anywhere in between. So that's a result of increased cost. It's also a result, though, of having a lot of uncertainty in the marketplace. With the open enrollment last year, you didn't know who you were going to get and what that experience was going to be. If you go back to my testimony, I speculated that Blue Cross and Blue Shield, our large carrier, they saw a phenomenon that because of the disparity between the individual market prices and the small group prices, there were a lot of small employers, thousands of them in Maryland, that just threw up their hands. They canceled their plans, they disbanded them, and those folks moved and migrated to the individual marketplace. I believe that, and this is my speculation, that a lot of those folks, that if they were already sicker and utilizing care, and they were with Care First, they migrated to Care First with the lower individual premiums, and those that were young and healthy, they were buying based on price, and they went to some of the other carriers. So I think that they were victims of adverse selection when thousands of these small employers just disbanded their plans.
Representative Holding, could I?
She was raising her hand first.
Oh, yeah, thank you. I appreciate the opportunity to respond. The year of data has been extremely helpful from the 2014 calendar year, but as I mentioned, our loss ratios were extremely high for that year. One of the functional challenges, though, is that because of the time schedule arranged by HHS, we were requiring insurers to file their 2016 rates before they had a very clear picture of their enrollees for 2015. Right. Because of the expanded open enrollment period and the 90-day grace period to pay premiums, insurers were filing rates for 2016 without even knowing who they had for 2015. Now, we are an effective rate review state. We take our rate review responsibility very seriously. So we are asking for supplemental information on a month-by-month basis as real data comes in for 2015. But it's still very, very new, and we haven't actually seen a large uptick in a positive trend on loss ratio yet.
All right. Mr. Chairman, Mr. Chandler have 30 seconds just to respond to that.
Yes, he does.
He's anxious.
Thank you. I would just say the following. Don't trust my numbers. Trust the Obama administration's numbers, at least on this. Their calculator shows a 14% increase in claims experience projected for 2016. Yes, of course, insurance commissioners can review rates, and if insurers are being greedy, they can strike that down. But if they strike down rates that are in fact reasonable due to claims increases, I expect to see exit from the market. It is not sustainable for an insurer to keep losing money.
Thank you, Mr. Chairman. Thank you.
Mr. Smith of Missouri.
Thank you, Mr. Chairman. I want to thank the witnesses for being here. The president campaigned aggressively on the promise to lower out-of-pocket expenses for families by roughly $2,500 a year. However, insurers that cover my constituents, just in the last 2 years, we've seen an increase by one insurance provider of 22.9% in 2014. This year, they've requested an additional 22.7% increase because of the one-size-fits-all approach under Obamacare of all the different burdensome regulations, rules, everything that's coming into place. But in my opinion, this administration cannot continue to believe that Obamacare will reduce costs for families and individuals throughout my district. That's not what I'm hearing back home, and that's what I don't believe is a reality. But the families in my district need a healthcare system with more choice, more access, and that's more affordable. But what I seem to be reading on a daily basis is that instead of more choices, we are getting fewer. The burden on insurers is so high that they are consolidating. Providers are also consolidating for the same reason. The extra cost and bureaucracy caused by the healthcare system from this administration has created. Now the Supreme Court decision may expose another broken promise by the president and the congressional Democrats to my constituents who may be required to get health care but may lose their subsidies. My question, Mr. Chandler, why do you think these premiums are increasing across the country and in my district?
I think the reason, first of all, is the continued escalation of health care costs, of underlying health care costs. And the Affordable Care Act did very little. Yes, it did a few things, but it did very little to address that. And in some sense, by providing insurance without effective utilization review to a larger number of people, it put yet more strain on the system. The second reason is the adverse selection story, which is perfectly foreseeable, where you have inadequate controls built into the law. The people who are going to purchase insurance are, as has been experienced, disproportionately ill. And that is one of the reasons that you see premium increases going up. The phase out of subsidies is a factor, but it is not the primary factor, in my opinion.
So do you think that with, say, the increase in all the premiums, I gave the example of 22.9% last year in my district and then an additional 22.7% requested, do you see that my constituents is getting an increase in benefits, or is it the same care or less care?
I am not aware that insurers are providing additional benefits pursuant to these policies.
Okay. So they're just getting the same kind of care for more expensive, probably. Mr. Kreidler, my concern is you made a statement earlier that you felt like things were looking a little bit better when it comes to premiums and that case. How do you feel like it's looking at individuals that are 27 years old?
Thank you for the question. I think from the standpoint of somebody who's younger, they're not immortal. They run the risks, and by virtue of having insurance, it's a lot better for them. If they're under age 26, frequently they can stay on their parents' policy. At the same time, you know, if you'd looked at the healthcare spending and thought you were going to actually reduce it in this country, I think that would be unrealistic, both because of an aging population, but also because of changes in healthcare delivery. Those costs are going to go up. What we have to do is bend that cost curve down so it doesn't go up as rapidly as it has in
And
the past.
that's my concern, is the cost curve. And I'm the second youngest Republican member of Congress. So when I look at a 27-year-old, and according to the Manhattan Institute, that their premiums have increased since Obamacare has came in by 97%, that's not managing a cost curve for the younger Americans. That, to me, says that they are definitely not going to purchase insurance if they're going to be a 97% increase prior to the ACA. What's your thoughts on that? It doesn't look like it's looking better to me as a young American.
I'm not familiar with any numbers like that from the standpoint
What
of
numbers are you
the numbers
familiar with?
I'm reviewing that you're describing. I'm not saying it's not true. I am not familiar. My actuaries aren't familiar with seeing those kind of numbers in my office. But
Do you have any numbers on individuals in their late 20s of the premium increases?
Yes, we would and do.
Do you know them offhand?
No, I don't.
Okay. I'd be interested to see what your numbers are.
Sure. No, it is. This is clear that I think the real challenges of what we face right now is bending that cost curve down as a nation, and we have to do it fairly and equitably. But leaving 27-year-olds without health insurance is obviously going to be a problem. The test is going to be making sure we're bending that cost curve down so they're getting adequate health insurance and so that they don't cost impact the rest of us when bad things happen.
I would totally agree. I think the cost curve causes us to lose more people that would have health insurance. Mr. Chairman, thank you for your time.
Dr. McDermott.
Thank you, Mr. Chairman. I appreciate your letting me be an adjunct member to the committee. There's a recent article in the Wall Street Journal talking about the conglomeration or the merging of healthcare providers and insurance companies. And they're talking about what's happening in a variety of markets around the United States. And and talking about antitrust questions. And the whole question, our fraud laws are really based, up to this point, on a fee-for-service system. I mean, the Stark Law and other aspects of it are really designed to deal with the fee-for-service system. Now we've got managed care and we've got all these things going on. I would like to hear you talk about where you think healthcare is going in terms of the mergers in these states where you're going to have, if the free enterprise system is based on competition, it means you got to have more than one or maybe more than two to have anything that could be called real competition. I mean, if it's just two gorillas dividing up the pie in the state of whatever, it becomes not very competitive. And so I'm interested in hearing your anticipation of where you think this scheme of Affordable Care Act is going to go in the future. So anybody can pile in. You want to start?
Yeah, I think your instincts are correct. I think mergers and a reduction of the number of carriers in and of itself is bad for the consumer, and is probably bad for providers as well, as the larger entities can extract greater concessions from the providers. Another observation, though, in addition to that, is there are a number of provisions of the Affordable Care Act that are encouraging and resulting in these hospital-owned provider organizations where physicians are becoming employed by hospitals. And I don't know about your states, but I can tell you in Maryland that market has come and gone a couple of times in the last 30 years. And at least in Maryland, these hospitals really haven't shown a lot of talent in running efficiently and cost-effectively physician practices. So I'm concerned that that's going to lead to greater inefficiency and greater cost in the long term.
Can I just clarify on that? One of the things that happens, of course, is if you buy a doctor's practice and you used to see patients in your practice and now you're seeing them in the hospital charges a facility fee of some sort, which jacks up the price on it. And people are very surprised that got over here for $30 and I'm now getting it for $75, having it done the same thing.
Well,
Doesn't that
there's
just
some of
drive up
that,
cost?
but there's some of that, but we're also seeing hospital-owned physician practices that are outside of the hospital setting. I mean, sometimes you just see the changing of the sign, and they are community-based and outside of the hospital, but they're not necessarily more efficient nor cost-effective than a individual practice.
Thank you. I would agree that your instincts are correct and that we are going to see continued consolidation on behalf of health insurers and providers. In a certain sense, while we all need to be concerned from antitrust issues, it makes a bit of sense from the insurer standpoint because they're looking to consolidate and gain efficiency in administration and gain provider networks. Now, on the consumer side, when the ACA limits the amount of areas upon which an insurer can compete, because all insurers have to offer products on the Essential Health Benefits platform, have to offer products on the metallic tiers with certain actuarial value percentages and amounts. The consumers appreciate that because it's transparency and it's easy to compare policies, but insurers don't have much to compete on at that point except for provider networks, administrative efficiencies, and anything else that they can distinguish themselves. They can no longer designate products and compete on that basis. So the ACA in itself limits some of those areas of competition that I think are leading to the consolidations that we're witnessing.
Mr. McDermott, I don't know that we can really attribute the consolidation that we're seeing right now in the healthcare environment, whether it's the insurers or providers, to the Affordable Care Act. I think, particularly in the case of providers, that trend was well underway before the Affordable Care Act. My concern is that we're now starting to see it with the insurers, which may be more of a reaction to providers doing it. Hospitals are buying outpatient clinics, and as you point out, they can charge higher rates. It means physicians. When I took office in the year 2001, most of them were not employees. Now you see a very large percentage of physicians who are employees because their clinics, they either sold their clinic to the hospital or they were acquired by the hospital and are now salaried. I worry about that. I also worry about what happens with the consolidation among insurers. And I think that's something that, as regulators, we'll have a mutual concern about to make sure we maintain the viability of the health insurance market, whether it's the providers or the insurers themselves.
Ms. Noem.
Thank you, Mr. Chairman. And Mr. Chairman, I want to thank you for mentioning my home state in your opening comments, because we do face some unique challenges in South Dakota with one of our largest insurance companies recently announcing some of the increases to premiums up to 51%, with an average of about 42%. So that is a lot for anyone to try to deal with in one calendar year, much less try to continue to insure their family and make sure they're making the best decisions. But what my question wanted to cover specifically was if the Affordable Care Act is requiring individuals and families to purchase coverage that they don't need. And this is one of the challenges that we've seen and possibly has driven up costs in line with that as well. So Dr. Chandler, I know that you've before in this hearing described why premiums are increasing. Could you just restate for me if you believe that Obamacare was meant to address health care costs and what it was, especially considering some of the testimony of Mr. Kreidler earlier? I want to have it clarified what Obamacare was meant to do to health care costs. What was the intention of the act, and how was it to impact health care costs for Americans?
Well, I would say the problem is that Obamacare, or the Affordable Care Act, conceptualized wrongly the problem as one within the insurance industry rather than a problem primarily located within healthcare itself as fed back to by insurance. And so while it attempted to deal with insurance, I believe unsuccessfully by and large, it really failed, with one exception I can talk about, to address the major problem, which is cost increases for medicine, more procedures, more costly procedures, as one of the gentlemen mentioned, higher pharmaceutical drug prices. And so the one exception I would say is the creation of accountable care organizations, which may or may not reduce costs.
But by and large, the act has gradually increased the burdens on Americans, you believe, since it's been enacted.
I do.
Ms. McPeak, in your testimony, you say Obamacare significantly changes requirements for health care plans. Can you briefly describe some of those changes?
Yes, I alluded to those a moment ago. You know, the Essential Health Benefits platform, I think, does require citizens to purchase coverages that they might not necessarily need and wouldn't choose to purchase on their own. What we hear frequently in Tennessee is, I am a 27-year-old male, I don't want maternity coverage, and I have to have a plan that includes something like that. So I do think the inability to tailor products to the needs of your individual consumers has been affected by the Affordable Care Act, and the insurers can no longer tailor those plans to the distinct segment of the population that they're trying to serve.
So could I buy a policy with fewer benefits that would cost me less?
Not unless it was compliant with the essential health benefits. I mean, you can certainly modify your cost sharing and your deductible amounts. You can limit the providers that you would agree to see under the plan, but the basic benefits have to be standardized under the essential health benefits platform.
So the federal government is requiring my constituents to buy benefits that they may or may not want at a higher cost to them.
We do hear that from our own citizens in Tennessee, yes.
Okay. Well, I just wanted to close with, we've talked to many individuals and families across my state and across the country. I'd be remiss if I didn't mention that rate hikes for small businesses as well. And I'm talking about the small group market. The law completely upsets the traditional small group market, lumping mid-sized businesses with small businesses. And this definition change would have a huge impact. In fact, studies from Oliver Wyman and the Agency for Healthcare Research and Quality estimates that 22,000 South Dakota employees and their dependents will receive cancellation notices. And most will see an average premium increase of 18%. So for Obama administration bureaucrats here in Washington, these 22,000 South Dakotans are not just points on a graph. They're people that will be impacted. It's their real lives. And with that, Mr. Chairman, I wanted to draw light to that, and I thank you for holding this hearing. I yield back.
Ms. Black of Tennessee.
Thank you again, Mr. Chairman, for allowing me to be here as a guest and have an opportunity to be able to ask questions. I thank you for bringing this very critical topic before the public so that those that are listening to this know that we do care about either the lack of care or the cost for them to get care. And I also want to say, Mr. Lewis, you are absolutely a giant in the civil rights movement, and it is such an honor to serve with you and get to know you personally. And I will get you my book so you can sign it for me as well. Ms. McPeak, I want to thank you again for being here. And you have in your testimony that there is a consistent uncertainty on the part of the Obama administration in the ACA's implementation. I can say that we have seen so many changes that the Congressional Budget Office, the CBO, has now said they're no longer able to even score the changes that have taken place. But most recently, there was a change that was released in the guidance of the market withdrawal. And according to the guidance, if the insurance company chooses to leave a service area or if they change the type of product that they are offering from, for instance, a PPO to an EPO, then the company is excluded from operating in that market for 5 years. The guidance was apparently issued after all the plans had filed their rates with the Department of Insurance, and meaning that it was too late for any of these carriers to revise any of those filings in response to what this guidance was. Can you elaborate why this guidance would potentially disrupt the market in Tennessee?
Certainly, and I do have very specific information about that particular guidance in my written testimony as well, because it was a distinct challenge for us in Tennessee. As you mentioned, the carriers had already filed their service areas and the rates for 2016 when the guidance was issued. And we have 8 different service areas in Tennessee, and the guidance suggested that leaving one service area was going to be considered a market withdrawal, and the carrier would be prohibited for 5 years from selling insurance in the state of Tennessee. Also, a change in the plan. So moving from a PPO to an EPO plan was considered a market withdrawal. So insurers filed the rates, didn't have any idea that this interpretation was outstanding. And then we received the guidance from HHS in this regard. And for Tennessee, that means that we would have lost 5 of our carriers for 2016 because of this guidance. And we were very, very concerned. We had a lot of conversations with HHS, and finally HHS agreed that they would only implement this guidance for plan years 2017 and beyond. So it's still going to be an issue going forward.
Could I
Mr.
further
Chamber?
respond to that?
Yes.
It's a very important development that you've highlighted, Representative Black, and I would urge the Congress to take a look at 2 things. First, is that guidance actually within the scope of the Affordable Care Act? This is traditionally an area of state regulation, and I really wonder what provision in the ACA authorizes it. The second thing I would look at is whether the McCarran-Ferguson Act actually prohibits this sort of federal interference in an area of traditional state regulation. So even putting the wisdom of the provision aside, I actually think there's a serious question that ought to be looked into, and for which for once there will be standing about the legality of this proposed, or this guidance.
I have a very brief period of time. Mr. Redmer, did you want to reply to this as well? No. Mr. Kreidler?
Yeah, I actually agree. I think as regulators, we found it a very difficult action on the part of HHS and how they applied it. So it was problematic. I think the real question is this one where HHS sees the problem? And the problem would be that if you come in with a new plan, you can totally avoid showing your rates as going up precipitously. I think it's all members of Congress, certainly the public, wants to know that information. They can't use it as a way of obfuscating significant rate increases. Make sure it's transparent. And if the only tool that is available to HHS is this draconian steps that they've taken, it is obviously one where maybe this is where you could get unanimity to amend the Affordable Care Act in Congress so that they have a tool that is much more sensitive rather than saying you're out of business for 5 years, which is the only option I believe that they have. It was inappropriate to try to do it the way they were doing it, though.
Thank you. Mr. Chairman, I yield back.
Mr. Smith of Nebraska.
Thank you, Mr. Chairman. Thank you for allowing me to join the committee today. I appreciate our panel today. I wish we had more time because I think we're covering some very important topics, and I'm concerned about the consumer-operated and oriented plans. It may be no surprise to you from Tennessee that being from Nebraska, we've had some issues. To date, HHS has awarded a reported $2 billion in federal loans to establish these plans. I've asked HHS some questions, and I await the answers even still. Co-Opportunity in Nebraska and Iowa served over 100,000 individuals, and it was seized by the state of Iowa after only 1 year and has since been liquidated, as you know. And people who were on these plans have been left confused, understandably, and frustrated as well. Once again, being forced to look for other insurance. Some even lost their plans that they were told they could keep, and so that's why they went to Co-Opportunity and yet lost that as well. Tennessee Community Health Alliance obviously serves some folks there. Now, it's my understanding that there have been some troubling signs and actual enrollment was suspended. Is that accurate? And that was suspended when?
That was suspended in the middle of January of this year.
Okay. And certainly I appreciate your work on the issue, and I know that these are difficult things to manage and to deal with. Now, my understanding was that the state of Iowa wanted to suspend enrollment, but were told they could not suspend and were forced to still offer the so-called qualified health plan. And can you walk me through the process that Tennessee engaged in to be able to suspend the enrollment?
Well, certainly. Thank you for the question. It was a very difficult time for us because we were first approached by Community Health Alliance that had been witnessing their enrollment increase substantially during the open enrollment period. And of course, the middle of January was still during the open enrollment period. We did a quick examination. We shared their concern. We considered the co-op to be at financial capacity. A few triggers in our state statute for hazardous financial condition had been met. We notified HHS, and I will tell you, our interaction was not as efficient as we had hoped at that point with HHS. They certainly had a differing opinion about the financial stability of the company. I took a very conservative approach, I think, because as Iowa and Nebraska experience, had something occurred with the co-op, it would be my responsibility to take receivership action or liquidation or seizure of the company. And so we were not comfortable with the level of enrollment. There was a tremendous amount of back and forth. Eventually, it did take about a week's time for HHS to agree to suspend the enrollment. But even that small victory, which again, as I mentioned in my comments, we think was the right decision for Tennessee, has been problematic for our Tennessee residents, because our residents that had a plan with Community Health Alliance had extreme difficulty when HHS froze the enrollment and suspended them from the exchange. There was no ability to add a child that was born or adopted or any other qualifying event, because in the mind of the federally facilitated marketplace, the plan ceased to exist. So all of those changes had to be performed manually, and it has not gone smoothly.
Very interesting. I'm curious, were you aware of Iowa's request to suspend enrollment?
I was not aware of the request to suspend before the seizure occurred. I knew that it was possible to stop enrollment and to essentially turn off the exchange enrollees, but it was, in my opinion, in Iowa and Nebraska only after the seizure was ordered.
Okay. You have a pretty good feeling about where the Community Health Alliance stands today?
At our request, Community Health Alliance has drawn down the full amount of startup loans from the federal government. We have a financial exam underway so that we know exactly where they stand. We've provided some helpful, we thought helpful information about administrative expenses to the company. And the rate request for 2016 that they have filed is over a 32% increase. I don't know that that's going to be sufficient to make the company sustainable and to remove the freeze for the upcoming year.
Okay. And to the best of your knowledge, is it true that only one of the 22 plans nationwide did not have an operating loss for 2014?
I did see a report that was consistent with that figure, yes, sir.
And would that maybe lead you to some concerns that maybe the loans, calling them loans, wouldn't be the most accurate description?
I would agree, yes.
Okay. Thank you. I yield back.
Thank you. Let me just, I've got just a question for each of you, and I'll, Mr. Redmill, I'll start with you because I know you've got a hard stop at 12 noon. So go ahead. You've got our permission to head out when you need to head out. But in your written testimony, one of the things that you said was that there's an insurer in your state that's predicting that their pool is going to be actually older next year. Could you speak to that? That seems, I mean, it's not a term of art, but that's a trend that's toxic, isn't it? I mean, what's the ramification of that?
Well, that's true, and that will obviously continue to drive up costs. So it's something that we're concerned about. Again, there's still a lot of uncertainty as to what the effect of the increased penalty will be, and whether that's going to drive any younger folks into the marketplace, or the flip side is the young folks will sit tight and remain uninsured, pay the penalty, and only those folks that migrate into the pool will be those that were uninsured and now are sick, which obviously will probably mean even a higher average age and increased morbidity.
So it's a ramification of adverse selection.
Correct.
Okay.
Potentially.
Ms. McPeak, could you give us any insight in terms of long-term trends that you're seeing in Tennessee as it relates to, other things, Cadillac tax and so forth? How is this playing out for you?
In Tennessee right now, we are hearing a tremendous amount of feedback from large employers that are concerned about being assessed what has been described as the Cadillac tax for having a high-value health insurance plan available to their employees and executives. Of particular concern, and I share this concern when I hear it from the employers, and I know Representative Black has probably heard the very same thing. the cost of on-site clinics for employers is being included in the value and the cost of that, that health plan, that high-value health plan for purposes of calculating the Cadillac tax. And employers, rather than, and that is a decision or a guidance that is underway through the Internal Revenue Service, employers, instead of paying that Cadillac tax, are instead choosing to close those on-site clinics. And it's very troubling because reducing healthcare costs and certainly convenience to the employees and potentially a lack or a reduced amount of a copay or cost sharing for attending or seeking service at an on-site clinic certainly seems to benefit all of us in reducing costs and providing care. And so including the cost of that clinic as a part of the high-value health plan for purposes of the Cadillac tax is certainly problematic, and we're hearing a great deal about that in Tennessee right now.
Mr. Kreidler, I realize that I've got the benefit of having John Lewis's book, many copies around me, and you don't, but on page 178 of that book, Mr. Lewis points out that one of his phrases is put all your cards on the table and put them face up. When I read that, I thought, wow, I've heard him say that. I was at a meeting in the back in that library behind us, and we had the commissioner of the IRS at the time. We've had several, but one of the commissioners of the IRS at the time, and Mr. Lewis, then chairman of this oversight subcommittee, said, put all your cards on the table and put them face up. Just saying, it would have been better if they had done that. They didn't, but my cards face up are this. I participated in the White House Healthcare Summit. This was when the Affordable Care Act was being debated. It was that event at the Blair House. You may recall it. It was an all-day long sort of thing. The president was there and members of Congress and so forth. One of the points that I made to the president is contrary to one of the arguments that you're making. And I want to get just a little bit of a better sense from you about why you're making the argument, and it has to do with Medicaid expansion. So one of the things, and I don't recall sort of chapter and verse about this interaction, but one of the points that I made at that summit was, look, isn't Medicaid expansion simply an expansion of welfare? And isn't Medicaid a terribly broken system? And if you have a terribly broken system, why would you make that a foundation upon which you build a whole healthcare reform movement? So a couple of minutes ago, you said, look, one of the reasons that it's working in Washington State is because of Medicaid expansion. I think that's a problem. I think it's a problem long term. So I'm from Illinois. Our Medicaid system is really a mess. You've got huge access issues on the one point. And you've got, okay, Medicaid is basically cost shifted in a lot of ways. I know it's split, but it's cost shifted onto the federal taxpayer. So isn't there a little bit of a cautionary tale in just Medicare expansion as being part of this remedy? And isn't that almost a structural weakness to the Affordable Care Act?
Mr. Chairman, one of the things that I find somewhat unique that we're witnessing, because we have expanded the Medicaid program, is that you're actually starting to drive the Medicaid program closer to looking like what we see in the commercial market. And that means both on the issues related to the networks that they have, which tended to be much very different than what we saw in the commercial market. And certainly, as we've all heard, if you're in an elected position in particular, is you look at the kind of rates that Medicaid offers to providers being considerably lower than what it is in the commercial market. We're starting to see that driven together. I think it inevitably has to. You cannot have the Medicaid market significantly underpricing what it offers to providers and not see that, in effect, almost be one where the commercial market is having to subsidize the Medicaid market. Public programs and the commercial market have to operate on a level playing field, and we're starting to see that driven together in ways that we hadn't before. But I believe that the real driver here is the expansion of the Medicaid program that's done it. Before this time, we had very little limited interaction with the Medicaid program operated by the state. Now we have routine meetings talking about networks, talking about rates and issues like that. So I think it's having a beneficial effect that kind of goes outside of just what expansion itself would have been maybe the focus of the discussion. It's actually, I think, helping medicinally to make sure that more people are insured, and you don't have this huge problem of uncompensated care happening, which obviously gets shifted then to other payers.
You know, any insight that you have on your experience, if you or your staff would be willing to share that with us, I think that would be helpful. So thank you.
Thank you,
Mr. Chandler, let's close out with you. I thought that your insight as it relates to the way I put it down in my notes when you were talking was the Affordable Care Act deals with a symptom, but not the cause. Symptomatically, health insurance rates are spiraling, but it doesn't deal with health care costs. What insight do you have moving forward? If you could hit a reset button, how would you focus in? And you heard my rhetorical answer to Representative Crowley when he was saying, what are we doing, and are we nostalgic about the past? No, there's nobody that's defending the past. There's nobody that's celebrating about various structural weaknesses and so forth. But if you had an opportunity to hit a reset button and focus in to say, all right, how do you actually do this? Where would you direct the Congress as it relates to dealing with health care costs, which, as a foundational point, if you get that under control, you're well on your way to an actual remedy.
Let me talk about 2 points, one big, one small. The big point is there may be some temptation on the part of Congress to regulate more, push it down, push it down. That's unlikely to be effective. That is, adding additional complexity to the system, which we're already seeing, is going to drive costs up. It is going to lead to more gaming behavior and more diversion of resources into how to beat the federal government. What we have in healthcare is a unique situation in which the consumer is basically taken out of the equation, and instead healthcare is mediated by insurers who may or may not have the best interests of the patient at heart and who may not have an interest in trying to figure out creative ways using technology and other means to drive down healthcare costs. And so one of the things I would urge you to look at, and I know this is abhorrent to some members, but I really believe you ought to look more at consumer-driven health care so that we get probably the most powerful force that you have, which is individual greed and individual desire to take care of oneself and one family, driving down health care costs. Let me give you my second little point. You may have an opportunity, for better or worse, to renegotiate the Affordable Care Act in the coming weeks. I would urge both sides of the aisle to take a serious look at that employer mandate. What it is doing is it is keeping people out of the individual exchanges, keeping healthy people out of the individual exchanges. If you want to stabilize them, if you happen to believe in the principles of the Affordable Care Act, those are the very people that you want in those individual exchanges so that we do not see an adverse selection death spiral. If you also believe in free market principles, you ought to think, why is it that we should be forcing employers to divert resources into the provision of health care, rather in some instances into the provision of things that employees may value more, like a higher paycheck with which to pay rent and buy fresh food and go to parks and engage in other activities that may be more likely to improve their health. And so it strikes me that there is an opportunity, and I grant you this is not the biggest issue on earth, but there's an opportunity to do some good here in an area which, if people really rethought it and took the blinders and ideology off, there's some room for gain.
Well, Mr. Chandler, Mr. Kreidler, Ms. McPeak, and Mr. Redmer, we are deeply grateful for your time and your attention today. I know I speak for every member here. We value your insight and your willingness to share it with us. And lo and behold, let the record reflect that the United States Congress had a hearing on the Affordable Care Act, also known as Obamacare, that actually happened to shed more light than heat, thanks be to God. So with that, the meeting is adjourned.